Hello friends, welcome back to my new video in my channel. And today we will discuss the continuation of the ICU acquired weakness which we started, and this will be the part 2 video. So this is ICU acquired weakness which takes into account the modifiable risk factors which are below down and the non-modifiable risk factors which are above. So, talking about the non-modifiable risk factors like severity of the illness. So, when you have a higher illness severity scoring, higher intensity of sepsis, multi-organ failure, prolonged mechanical ventilation, prolonged critical care illness, and the high lactate level, along with the demographics as female sex, the older age, and the pre-morbid obesity. So these are the non-modifiable risk factors. Talking about the modifiable risk factors, so things which you can control and you can actually help mitigate the problem of ICU acquired weakness is hyperglycemia, the parental nutrition, the most important drugs, and we'll come to that, and of course immobility. So the present day understanding of ICU management is such that you know you are supposed to actually mobilize the patients as early as possible. So talking about the diaphragm, and it is actually seen when you have a rapid disuse atrophy of diaphragm in mechanically ventilated patient as early as 18 hours and till about 69 hours of mechanical ventilation and diaphragmatic inactivity. There was atrophy of slow twitch and fast twitch fibers, which leads to difficulty in weaning. So this was a very old paper from New England Journal of Medicine in 2008, and this is how the changes in the fiber size and the expression of the slow twitch and the fast twitch myosin heavy chains which are seen in patients undergoing mechanical ventilation. As you could see, this is the fiber size and the slow myosin and the fast myosin heavy chain, and these are the changes which occur. And you could see that these fibers are less in number on the right side, whereas on the left side, on the case side, you could see that after about 18 to 69 hours of mechanical ventilation patients, and when you have kind of the slow twitch and the high twitch fibers, you could see the definite morphological changes as compared to the controls. The classification of neurological causes in intensive care is very standard. The spinal cord has a localization, and the causes could be either trauma, infarction, and transverse myelitis. Anterior horn seen in either amyotropic lateral sclerosis or poliomyelitis. Peripheral nerves, the classical Guillain-Barré syndrome or CIDPs or chronic inflammatory demyelinating polyneuropathy. Neuromuscular junction, classically myasthenia gravis, botulism, and of course some muscle problems like muscular dystrophies, polymyositis, periodic paralysis, metabolic or congenital, and mitochondrial defects. So also this could be actually previously undiagnosed, either in the form of uh, the rhabdomyolysis or toxic myopathies, and of course hypokalemia and hypophosphatemia. So these are all the very classical classification, and this is very very important clinically, as when you see a patient with whether there is a spinal cord involvement or an anterior horn involvement, peripheral nerve involvement, neuromuscular junction involvement, or muscle involvement, you can relatively easily find the source from where the weakness is coming. So this is just a pictorial definition of these particular causes. So if you look at Guillain-Barré, it could be either autoimmune mechanism or myelin loss, and you have a diarrhea or prodromal syndrome caused by Campylobacter jejuni. Myasthenia gravis, again autoimmune mechanism, and they can have bulbar palsy with ventilator failure. Porphyrias are due to porphyrin accumulation, and they can have motor axonal neuropathy and autonomic instability. Eaton-Lambert syndrome, which is a paraneoplastic syndrome, presents classically with proximal weakness and autonomic instability. Amyotropic lateral sclerosis, having upper and lower motor neuron degeneration with bulbar involvement. Vasculitic neuropathy, where there is occlusion of vasa nervosum vessels, and it presents with paresthesia, numbness, pain, and weakness. Cervical myopathy, which can be secondary to mechanical injury to the cervical spinal cord, and classically presents as paresthesia, numbness, pain, and weakness. And of course, botulinum, which presents classically with descending paralysis as compared to ascending paralysis, which is seen with Guillain-Barré syndrome. So this could be a very, very striking differentiating point between botulism and Guillain-Barré syndrome. So coming to the reversible causes of neuromuscular weakness, and we had actually discussed in that particular slide, so I'll, I think, skip this slide, but here I want to stop and make sure that you don't miss on these drugs. Importantly, diuretics, which can cause hypokalemia, corticosteroids, statins, colchicine, cyclosporin, chloroquine, L-tryptophan, penicillamine, which has myotoxic or rhabdomyolytic effects, amiodarone, streptokinase, which may have demyelinating neuropathy effect, and magnesium, which can cause hypomagnesemia. So the clinical features of critical illness polyneuropathy, which usually develops within 2 weeks or more of ICU admission due to prolonged mechanical ventilation, and they take a little long to get weaned from mechanical ventilation. They can have limb muscle weakness and atrophy, reduced or absent deep tendon reflexes, loss of peripheral sensation to light, touch and pinprick, and relative preservation of cranial nerve functions. And as far as clinical features of critical care illness myopathy, it could be flaccid quadriparesis, proximal more than distal, failure to wean from mechanical ventilation, facial muscle weakness, which is relatively common, and extraocular muscle weakness, which is actually rare. So in short, if we talk about the diagnostic algorithm, so you have interruption of the use of sedatives and analgesics, and the patient is awake and he follows simple verbal command. You need to assess the MRC score, which we discussed, and you have a cutoff of 48, as we just we discussed. So normal findings, they are okay. If the score is less than 48, you need to have serial examinations, and if there is improvement, then there is no problem. If there is no change, then you need to go ahead with the other studies which we look at. If you have a focal deficit, and again the deficit in the peripheral nervous system, you should go ahead with the tests. As far as the patient who is not conscious, you need to withhold the sedation, and if he remains unconscious, then you need to actually go ahead and do a CT scan of the brain, MR brain, EEG, and CSF studies. As far as the other group is concerned, we actually know that we go ahead with nerve conduction studies, EMGs, and muscle biopsies if required. And there, if you find the preserved nerve conduction velocity, there is no demyelination, and reduced amplitude of motor and compound sensory nerve action potentials, you are likely to encounter the condition of critical illness polyneuropathy. Whereas if there is reduced amplitude and increased duration of compound muscle action potentials, you are probably looking at critical illness myopathy. So this is probably a very, very simple kind of flow chart which you can actually go through. So I think at this point in time I'll stop. We'll see the differentiation in the next video, and here we have discussed about a very, very easy diagnostic algorithm. As you could see, and I think the next part I will continue in my part 3 video. Till then, I think I'll stop here. Tata, bye bye, and take care of yourself, my friends.